for a long time, sepsis was sort of at this intersection between government and healthcare providers and academics. But of course, it's the American way to thinking about having technologic partners from the business world. And I think we've heard all day long a potential role for expertise that might come from industry partners, not just from the traditional sort of pharmaceutical or diagnostic companies, but increasingly there could be a key role, especially in something like sepsis, to have partners from companies such as Google. And this must have been on your mind, Michael, even from a career standpoint, as you made your move to Google. So I would love to hear your reflections on the day and any comments you have with regard to the 5 points I made at the start of the session.
Yeah, and maybe I'll set a little bit of context. So Derek and Saul asked me to talk about how do technologists and technology companies think about sepsis, which feels like a weird, for me, feels like a weird way to approach the problem. So I'll tell you, 30 seconds about my background, which is from, 1995 until 2017 was either training to be or being an intensivist. Worked on sepsis research for 15 years. A bunch of the early lactate work came out of our group, which apologies or other things, and then did quality improvement for a long time. Focused on critical care quality, and then was the chief quality officer of a good sized academic health system, and then I've been at Google for 3 years, and so I will answer Derek's question, but it comes out of that approach of having thought about sepsis for a long time. And I want to start with saying thanks to the National Academy and to the Moore Foundation for the focus on diagnostic excellence in sepsis, which I think is a really hard problem. And I'll tell two stories that I think highlight a bunch of the things we've already heard in this discussion. So maybe 5 Thanksgivings ago, we're beginning to sit down to Thanksgiving dinner. We have some friends over and my phone rings. It's my mom. I'm like, my mom's calling on Thanksgiving. This is amazing. And my mom says, oh, your dad's in the emergency department. I don't know what's going on. He's been cold for a day and a half and he started shaking uncontrollably, but we could talk to him. But we don't know what's going on. And we went in and he had a fever. And so, of course, my dad, right, had been sitting, he was actually on traveling with family, but of course, he had been sitting at home for a day and a half and ended up having, gram-negative broad bacteremic sepsis with high lactate and a little bit of AKI, and was at a small community hospital in the suburbs in Texas and got completely guideline concordant care and did great. So thank you, Laura. But my dad didn't know. And so one of the questions I have, which I have not heard discussed, is what is the role for the elimination of sepsis and for the early recognition of infection in a way that sort of when we started the central line journey, the idea of eliminating central line infection sounded stupid, but we have almost done that. And so I think that's one of the questions that I'd love to hear people think about. The second story that I'll tell as we talk about trade-offs is my mom's story. So this time last year, my mom was in the process of dying of gastric cancer. And one of the things that had happened in her course of disease, that she had a pretty substantial pulmonary embolism, which I will say for a couple of days was lightly diagnosed or underdiagnosed and was treated as sepsis. And 3 weeks later came down with really pretty significant C. diff, which in addition to sort of all of the things that we think about C. diff is a quality of life destroying disease in addition to the mortality effect. So there really clearly harms on both sides of those things. And I think that those have come out in the discussions, but for me, it sometimes is easier to think about an individual case instead of the statistics. So let me come back and address address Derek's question, which is really what is the role of technology here? And I would say that I am hopeful, but I am cautious. And I'm cautious in the following way, that it's very easy to hear that artificial intelligence will tell you the best treatment for every patient and it will get all the diagnoses. And we are nowhere near any of that. And so that maybe the two things that I want to leave the group with is, what is machine learning good at? So it is good at the way that we often say to Google is, today it is easier to program a computer to learn from examples than it is to program it than it is to hard code it to be smart. And the second is, it's just really good at learning patterns of what people do that get reflected in the data. And so that adds some complexities here. And it means that it's really, really, really important to remember that AI and ML are math, not magic. So what do I mean by that? I mean that there is fundamental baked-in ambiguity around sepsis and sepsis diagnoses, particularly around infection. You can look at studies that our group did around ventilator-associated pneumonia, where we enrolled 43 centers and asked them to rate, vignette-based cases, and the kappa was 0.1 between centers, which is disastrously bad. You can look at Clompus's work, where with intensivists, the kappa for vignette-based sepsis cases was 0.25. You can look at things again and again and again. AI is not going to help with that because it's baked into the data and it's baked into the practice. And the other thing that I think we've seen in a lot of very high-profile cases related to COVID is that machine learning doesn't solve fundamental epidemiologic problems. It doesn't solve missing data. It doesn't solve confounding by indication. It doesn't solve all of these difficult things that we learned about in public health school. It just makes them harder to detect because the analytics are more complicated. So I think those cautions are really important. And then finally, I'll answer the question that I was asked, which is, what is technology good for in the next, not in the next 30 years, but in the next 3, 4, 5 years? And I think it's a few things. One is interoperability, the ability to share and see data. We've seen policy movement in that. We've seen technical movement in that with FHIR and some of the additional HL7 standards. There's a lot of work to be done there, but that is one place. It's now technically possible to join data sets that previously you just couldn't do because of storage and computation problems, imaging, genomics, other kinds of data. And then finally, Chris Seymour's work and others have shown us that some types of machine learning are good at helping us find new patterns of disease and new phenotypes. And the last piece, which is mostly what our kinds of teams work on at Google, is the idea of what are things that can be seen clearly in data that are patterns that humans aren't necessarily good at. And so probably the best examples of this are around machine vision, around pathology, around radiology, where we've seen, physician compatible kinds of performance in a number of different machine vision domains or imaging-based specialties. And we're also starting to see that in some data around electronic health records of helping detect when patterns in data might be unusual for the given practice site. So I think that there are areas where machine learning is likely to be really helpful. But I'm also cautious that many of the claims that you see, the technology isn't there yet. Maybe I'll stop there.